So join in. The Crisis Jam is starting now.
All right, welcome. Welcome to those of you who are just tuning in to this week's Crisis Jam. We have so many wonderful speakers lined up today, including Dr. Matt Goldman, who is the medical director of the crisis system in King County. He will be sharing with us today on accountability in action, looking inside King County's crisis system. Very excited to have him here today. Recently, the Crisis Jam website got a bit of an upgrade. And so there's a new Crisis Jam website that we would encourage you to take a look at. There's so many wonderful resources there. You can watch the live stream there. You can sign up for the Zoom link to attend each week. There's a newsletter so you can stay up to date. And in case you missed any of the episodes, there are links there so that way you can follow along, get caught up, and make sure that you get all of this wonderful information. Crisis Jam also has a YouTube page. If you happen to be watching live from there now, go ahead and click that like and subscribe button. And again, you can catch up there. This year, 2026, we have some new hosts, including myself, which is just so wonderful to get to join Megan and Brian, Laura and David. We will have Sean coming on board too, Sean Russell from Global Leadership Exchange, and there will be one more host who will be announced in the coming weeks. Just thrilled to be a part of this and to get to bring some exciting energy and a new perspective maybe to the Crisis Jam. So thanks for having me here. Last week, we had a fantastic debate on whether or not medical clearance should always be required for admissions to a crisis facility. And in that pre-debate survey, about 20% of folks said yes and definitely yes, medical clearance should be required. And 60% said nope, absolutely not, should not be required for admission to a crisis facility. And then we saw that shift in the post-debate survey. That moved to 15% said yes, and 72% said no. So just want to thank Monica Johnson, who moderated that, Kevin Curtis and Jonathan Thomas for doing such a wonderful job on that debate and sharing their expertise around this topic with us. We have more debates coming up. Next one is whether mobile crisis teams should go into the community in pairs or not. This is such a hot topic. If you work on a mobile crisis team or if you're looking to implement those where you live, you know that this is a big debate and one that comes up often. So we will have Megan Gleason, who will share one perspective, and Dr. Ken Meekoff sharing the other, and looking forward to that. Okay, now we're moving on to the workforce segment. Would love to invite Susan Lang up. Susan is the Director of Workforce Innovation Lab, the Advocates for Human Potential, who's just a fantastic sponsor of the Crisis Jam. So Susan, I will turn it over to you. Welcome.
Great. Thank you so much, Heather. Hello, everybody. It's great to be here and really excited to have a few minutes to talk about the crisis workforce today. You may remember the last time we did a workforce corner. We focused in on using data to really understand what's going on in the crisis workforce. And so today we're going to build on that conversation and we're going to dig in more on the stories behind the data. And so I'm joined today by two of my colleagues from AHP, Erin Elaine, who is one of our staff consultants, and Ziamara Romero, who's a senior program manager, and they're going to share the work that they've been doing on qualitative analysis. So I'll turn it over now to Erin.
Thanks so much, Susan. Good morning, everyone. Thank you so much for being here with us today. As Susan said, my name is Erin Elaine. I'm a staff consultant working with the Workforce Innovation Lab at AHP. I'm a subject matter expert and also a qualitative researcher. I'm joined today by Zio, who will introduce herself shortly as well. Before we dive in, you see this great poll on your screen, our AHP Workforce Corner quote. We're going to start with this, and you'll notice you can only pick one answer, even if more than one feels true or if none of them feel quite right. So the question you have in front of you is, what do you see as the most significant skill gap in hiring crisis services staff? Please select one option as the top skill gap. So we'll give you a little bit to figure that out and select your top option. All right, so hopefully we'll be able to see the results of that poll. If you felt a little uncomfortable answering that and trying to figure out one option that fit quite right, that was intentional, right? We want you to answer as best you can and kind of notice how that feels. For some of you, that probably felt straightforward. For others, maybe a little uncomfortable or limiting, as I said, and that's exactly the point. The point we wanted to make is that close-ended questions give us some clean data, but they don't always give people room to explain their reality. Qualitative questions create that space. They let people say, it's not just one thing, it depends, which is often closer to the truth in crisis services work. Awesome. Today, we want to briefly talk about why qualitative research. Thank you very much. Looks like our top poll option here was ability to work in high acuity and unpredictable environments, followed very closely by prior crisis intervention and de-escalation experience. Interesting. We'd love to hear more, which hopefully we'll be able to get into, maybe a future workforce session. Today, we want to talk briefly about why qualitative research, things like interviews, focus groups, and listening sessions are so critical to truly understand the crisis services workforce, especially in combination with quantitative data. This isn't about research for research's sake. It's really about creating space to surface what's actually happening on the ground in crisis services settings and making sure those realities inform planning, funding, and leadership decisions. Next slide, please. When we talk about workforce data, most systems start with numbers, and those numbers absolutely matter. We heard of that in a prior crisis jam from my colleague, Mike Sophis, as Susan mentioned. Vacancy rates, turnover, time to hire, caseloads, those tell us how many people we have and where the pressure points are. But what numbers can't tell us as clearly is why people are leaving or why they stay. This is why our team at AHP advocates for using both quantitative and qualitative data. That qualitative data helps us understand what it actually feels like to work in crisis services. It captures the realities behind the metrics: burnout, pride in the work, barriers to advancement, supervision challenges, and importantly, the emotional toll of running 24/7 systems. For leaders, this aggregated why may often be the missing piece, allowing for major themes to emerge from across the workforce spectrum. It's what allows us to move from reacting to workforce shortages to designing solutions that translate staff experiences into really clear, actionable recommendations leaders can use to improve recruitment, retention, training, and system performance. Next slide, please. So what does this look like in practice? When we do qualitative talent pool assessments, we're very intentional about what we explore at AHP. We look at things like how people enter the crisis workforce, skill gaps, and whether roles and expectations are clear and realistic. We pay close attention to supervision, training, advancement, and how staff experience leadership and organizational culture. Most importantly, we think a lot about creating safe conditions for honest feedback. People working in crisis systems are used to holding everything together. Qualitative approaches give permission to say, here's what's actually working and here's what's not. And that honesty is what allows leaders to make informed, sustainable decisions. I'll pass it over to my colleague, Zio.
Thanks, Erin. Hello, everyone. My name is Xiomara Romero. I also go by Zio. I'm a senior program manager, as Susan mentioned, at Advocates for Human Potential. So good to be here with you all today. I'm going to be focusing on highlighting why priority populations and cultural responsiveness are essential when gathering qualitative data. Crisis systems fail when workforce planning ignores culture, language, trauma, or when peers are treated as add-ons rather than core partners. When these elements are overlooked, voices are unintentionally excluded and burnout increases across the workforce. When we engage the crisis workforce in feedback, evaluation, or systems improvement, how we collect information matters just as much as what we collect. Trauma-informed facilitation is essential, and it's a core strength of our work at AHP. People are more willing to share honest, meaningful feedback when they feel psychologically safe, respected, and supported. In our recent national evaluation of certified community behavioral health clinics, I will highlight how we embedded trauma-informed and culturally responsive practices throughout the data gathering process. This included bilingual interviews, youth engagement, culturally responsive facilitation, and clear communication about expectations and boundaries. By prioritizing trust and participating well-being, we gather richer, more authentic insights while minimizing harm. Strong confidentiality protections are also critical. These safeguards must be clearly communicated and consistently upheld, while still allowing systems to move forward efficiently. Whenever appropriate, feedback and data collection should follow an IRB or IRB-informed protocols, especially when working with sensitive populations or topics. At AHP, we maintain our institutional review board to ensure our research and evaluation activities uphold ethical standards, protect participants from risk, and minimize harm to communicate what we serve. So transparency about how data will be used is essential. So staff understand that their input supports systems improvement, not performed management. Ultimately, these practices are foundational to workforce engagement, retention, and sustainable crisis system improvement. Next slide, please. So I'd like to close off with, leave you with this quote in response to the question, why do you think qualitative input is important when trying to understand workforce challenges? Running 24/7 programs, and especially in crisis intervention capacity, presents unique leadership challenges that are often not understood by broader mental health systems. Having the ability to describe those dynamics as part of a qualitative process demonstrated the work of 988 centers is being seen. Thank you, Nargis, who gave us the permission to use this quote today from our work with the talent pool assessment for the California Crisis Services in conjunction with DHCS. Nargis, if you're here today, I welcome you to comment in the chat, and stay tuned for our next Workforce Corner Jam on next week, featuring our colleague Mauricio Martinez talking about career pathway and mapping. Thank you all.
Thank you so much, Susan, Erin, and Seal, for the work that you are doing to help us understand what's behind these workforce challenges and to move in a direction of being able to more adequately support our crisis workers. So now we are moving over to breaking news, and we have Leah Pope joining us to talk about the mobile crisis survey that is open. Leah.
Hi, good afternoon, everyone. Nice to see some familiar faces and some new faces as well. Many of you have probably already seen advertisements for this national survey of mobile crisis teams, but we wanted to remind everyone that this survey is open and in the field through January 31st. And so if you are a mobile crisis program, please participate if you haven't done so already. Just a couple of quick highlights to reorient everyone post-holidays. One is that we are defining mobile crisis program very broadly and intentionally so to really build the evidence base for what counts as mobile crisis across the country. And so we are asking programs to participate if they consider themselves a behavioral health provider mobile crisis program, an MRSS team, an alternative or community responder program, as well as a law enforcement-based co-responder program. So it's really open to the wide range of programs. As you can see from this map, we already have great participation. We have 383 programs who have either completed the survey or have it in progress. And we have another approximately 400 programs who have shared their program name with us and we've sent the survey to. So I think this is really promising in terms of our efforts, but we really need your support in the field to make sure your partners know about this, that your communities are motivated to respond. and that we can really start building on what we already know about mobile crisis to really learn more about what's going on in the field. We will be asking, the survey covers a variety of topics. We ask about service area and type of service. We ask about the partnerships your programs have, team structure, and the number of FTEs, the program employees. We also ask about things like training, technology, and financing and data collection. So we are really excited about this. I think it's great to see that we've had such high participation so far, but there's a ways to go, and our team is available and happy to answer any questions that people may have about the survey.
Wonderful. Thank you so much, Leah. Grab that link or scan the QR codes. Maybe we can put that link in the chat. Now it's
Yes, I'll
time
put it in the
for
chat.
the hot seat. This is such a fun segment of this show. So we will invite up Sabrina Taylor with Phoenix PD, and then Michelle Saunders from CIT International will also be joining us. Let's see.
Good morning.
Good
Good
morning.
morning.
Welcome.
Yeah.
I can see Michelle. Do we have Sabrina joining us as well?
Yep. She's there.
Yep, I'm here.
There you are. Okay, great. I
She's
couldn't
got my
see.
name attached to her.
Oh, yeah, because I had to use Michelle's link. That's why.
There you go. Oh, so good to see you both. Thank you so much for being here. All right, so the question today, we'll
Ooh.
start, I believe, Sabrina, with you. In 2023, King County voters approved a levy to fund new crisis care centers. How many total facilities does that levy ultimately fund? We'll pop up the answers here. And I think through those, do you think it's 2 facilities, 3, 4, or 5?
My goodness. Of course, you'd ask me a numbers question.
You will see that just popped up for the group to answer as well. So take a moment there to be entered to win some swag, Crisis Jam swag.
I don't know. What do you think, Michelle? When in doubt, I always pick B.
So this is just for King County, correct?
Yep.
Yeah. It's a lot of money to fund a crisis center. And I'm not quite sure how big King County is, but I think it's pretty large. I was kind of leaning toward 2, since it was sort of just come on board and maybe kind of on each side of the county to get started. So I was leaning toward 2, but I could see 3. I wouldn't go past 3, though. I think that would be, I mean,
Dr. Goldman says there are 2.3 million people in King County. It's the Seattle
thank
metro
you.
area. So does that help out at all?
It is large.
Yeah, I'm with you, Michelle. I'm kind of thinking too, because they're very difficult to fund and they are just starting. I mean, when we were there in 2019, they had 3 mobile crisis units, and that was probably about it. So,
We're
oh,
getting
David asked me
something
how
in
many
the-
in Phoenix. About a little over 1 million, but like LA is 4.5 million, and they don't have that many facilities. So,
All right. So
And
where are we landing here?
So you want to go with what the group's saying? Go with 3? Or you want to stick with 2?
well, I guess I'll go if they think B too.
Yeah.
Maybe we'll split the difference and go 3.
Okay.
All right.
I'm with you on that, Sabrina.
Okay, so 2 years ago, King County voters approved a levy to fund crisis care. How many total facilities did they fund?
Oh,
5.
holy!
I
Wow,
saw the
they went all
Stephanie
in.
comment.
Yep. When fully built out, King County's crisis care system will provide more than 100 crisis stabilization chairs across its facilities, which is just incredible. Thank you both for talking that out and kind of phoning a friend there in the audience. Now we're going to move to the over-under segment. Thank you, Cookie Monster, for getting us here. King County again. So voters approved a major mental health levy in 2023, funding facilities, mobile crisis, and more. How many voter approved funding measures for crisis facility has Crisis Jam highlighted over the last year? Michelle, why don't you pick a number and then Sabrina will have you say if you think it's more or less, if it's over or under.
How many voter-approved funding measures for crisis facilities has when I think of sort of the Southwest, Tucson, Phoenix, in Texas. The last year, I think Crisis Jam is highlighted, say 10. That
10.
might be high,
Right.
but I'm going to say about 10 because for the whole year, I think that's been a big focus and really doing shout outs to the various crisis facilities and a
Okay.
strong element to the crisis system. And so I'm going to
All
say
right.
10.
Going with 10. Sabrina, over or under?
Oh boy. I was thinking about all of the 988 and tax initiatives, but if it's just the last year, and I saw Kristen
Voter
put in,
approved.
okay, how many we've talked about and voter approved, then that would be a much lower number than I was thinking. I don't know, Michelle, you might be right on. That's like one a month.
All right, you gotta pick over or under. What's your gut telling you?
Oh, I'm gonna say over, but not by much.
All right, let's see where that lands. So we've talked about King County, Franklin County, Ohio, Maricopa County in Arizona, and Pima County, Arizona. So under
Oh.
4. Yep. Thank
Okay.
you both so much for being good sports and participating there, and for everyone who is watching who participated in the poll.
Thank you. It's fun.
Yeah. Okay, now moving over to our lead story. Again, we have Dr. Matt Goldman with us today. He's the medical director of the crisis system in King County. And we'll be talking about accountability in action, looking inside King County's crisis system. Dr. Goldman, I heard that you were trying to win an award for most times on Crisis Jam, and we're so grateful for that. Welcome. Thank you for being here with us today.
Thank you so much. It's great to be back. Great to see everyone, and really excited to share about our crisis system in King County. And I want to focus today on accountability. And what do we mean by accountability, implementing accountability systems in our crisis system? Just to start with an overview of operationalizing accountability and what I mean by that, there's a concept called accountable entity, or a term that's often referenced, accountable entity. This comes from the Roadmap to the Ideal Crisis System report, and it defines accountable entity as a structure that holds the behavioral health crisis system accountable to the community for meeting performance standards and the needs of the population. And there are numerous different models of these structures. And so the goal here is really for a system to be accountable to those who we're serving. And crisis systems need that accountability because we got to make sure that we're funding the right things and doing the right things to actually meet the needs of the population. And there's a lot of different ways of doing that. On to the next slide. In the same roadmap report, there's a lot of different layers to implementing an accountable entity. So you can see there's the person in the middle, Mr. Y. That's who this whole system should wrap around. But around them, there's many different layers, including clinical best practices, the actual services that are implemented. But it's that outer, excuse me, that outermost ring, accountability and finance, that's really meant to hold the whole system together, and ideally is coordinated and robust to ensure high quality services being implemented throughout the system. And so that's where I'm going to focus today. On to the next slide. There's also a more detailed description of quality measurement in crisis services that was put out by our Crisis Services Subcommittee and the Medical Director Institute, which we're going to link here in the chat, and gets more into specific metrics that support accountable entity implementation. So with that in mind, I'm going to give an update on our crisis system here in King County, the Seattle metro area. As has been mentioned, love the hot seat and the already discussion about the Crisis Care Center's levy in King County. In 2023, voters approved this initiative, this is a $1.2 billion investment. So you're absolutely right. 5 centers sounds really expensive. It is very expensive, and we are very fortunate in King County to have a tremendous property tax levy investment by voters to support this initiative. And the funding goes 2024 through 2032, although there's many plans to pursue longer term sustainable funding to support these services. An implementation plan was developed. There was extensive engagement with community partners. So sort of the starting point of accountability is going to the community and asking what's needed. There's also extensive engagement with elected leaders in order to have that political support to really pursue what's needed at scale to stand up this system. And so the focus was on investing in somewhere safe to go in the continuum, but there have been investments throughout the continuum. So so for example, someone to contact and someone to respond. There are some investments in the call centers and mobile crisis through the levy as early investments while we're working on standing up the facilities. So anyone in King County can, of course, call 988, but there's no availability of specialty teams to respond. We have our adult mobile teams and our child MRSS program. We also, through the levy, are expanding a 911 diversion program that's in partnership with our local PSAPs in order to divert 911 calls to behavioral health resources. And so that has been part of our investment and is all getting implemented. On to the next slide. There's also, of course, the crisis care centers themselves. So what is a crisis care center? Well, it's a place where anyone can go to receive immediate care for a wide range of mental health or drug and or alcohol challenges. Staffed and open 24/7, you can walk in and you don't need insurance. And the program model includes 3 different components. There's a behavioral health urgent care that's open 24/7. There's a 23-hour observation unit that's for a higher acuity setting. That's also the receiving point for first responder drop-offs. And then there's a crisis stabilization unit where folks can stay for longer periods of time if they don't need inpatient admission, which inpatient would happen outside of the crisis center itself. One of the 5 centers that we're standing up is going to focus on youth. And there's also a significant investment in post-crisis follow-up, which I'll share a little more about in a moment. On to the next slide. So our future crisis care centers, in terms of how we're actually standing these up in 2025, last year now, we opened our first center in Kirkland. We are also excited that we were able to purchase a building and select our operator for the crisis care center in Seattle. Both the Kirkland facility and the future Seattle facility will be operated by Connections Health Solutions. We've also selected our post-crisis follow-up providers. And next year in 2027, we anticipate that Seattle Center will open. And the goal is that by 2030, all 5 of the crisis care centers, including that youth facility, will be open and operational, which will be geographically distributed across the county in central, northeast, and south regions. Next slide. I mentioned post-crisis follow-up. Many of you have heard me over the years talk about, well, if you're standing up a crisis program, you don't want it to be a bridge to nowhere. We don't want to create access to an acute service without anywhere for someone to go afterwards. This is the Achilles heel in crisis systems. As far as I'm concerned, it's very challenging to support people in the aftermath of a crisis because the crisis programs themselves have to focus on responding to new people who are in crisis. And so we have a significant investment through the levy to stand up a post-crisis follow-up program. There's a strong emphasis on culturally and linguistically appropriate services to ensure that this program meets the needs of populations who often experience inequities. There's a multidisciplinary staffing model that will be implemented in this program. It's a high intensity program that's also time limited. So weekly engagement, think almost like wraparound or act level service, but for at short duration in order to bridge somebody to a downstream program. And this program will start by prioritizing people who are coming out of a crisis care center in order to really build out that workflow. So we're very excited to stand up this part of our program as well. Okay, so with all of that in mind, so I started talking about accountable entity. What does it mean to operationalize accountability? We've got all these services that the levy is supporting. So that's obviously the bulk of the investment. But we also in King County are doing a lot to operationalize accountability through multiple different features. And so that's where I'm going to focus the remainder of my time. So first of all, we are fortunate in King County to be, I don't know if it's uniquely, but definitely strongly positioned as it relates to financial authority. So our county system, so I'm in the Department of Community and Human Services. We have a behavioral health and recovery division. We are responsible for administering both the levy as well as an additional local behavioral health sales tax to generate local revenue. We're also the delegated Medicaid managed care authority for behavioral health benefits for King County residents. So any King County Medicaid beneficiary, their behavioral health premium comes to the county, and we manage those funds in a managed care, utilization management, et cetera, capacity. We also administer non-Medicaid state general funds as well as federal block grants that are passed through to us. And we also have a lot of other investments that we don't manage directly, but that are in our ecosystem. So there's extensive state funding. Washington State was the first state to pass a 98 cell phone fee. We also have significant municipal investments. So our cities, especially Seattle, Redmond, Bellevue, others, have significant investments in crisis-related services, especially in co-responder programs that are both law enforcement and also fire and EMS based. And so with that landscape, we have many tools at our disposal in order to braid funding and really synergize all of these different fund sources in order to maximally leverage our ability to implement a continuum of services that's going to be of greatest impact to the communities we're serving. We also have a strong equity framework as our foundation. There's no quality without equity, and there's no equity without quality. And the Crisis Care Centers levy in particular, there's a focus on increasing access to care for populations that historically have experienced and continue to experience behavioral health inequities in their outcomes. Again, increasing access to culturally and linguistically appropriate services, increasing the representativeness of the behavioral health workforce. We know that having a workforce that's representative of the population served can increase quality, and also implementing accountability mechanisms. And that's really what I'm going to focus on this next slide. This slide has a ton on it. This is the $1 million, well, you could call it a $1.2 billion slide, or at least part of implementing that overall investment. There is a wide range of accountability activities that are made possible by the levy, and this is the operationalizing what it means for us to take on that responsibility as an accountable entity in our system. The levy invests directly in the behavioral health workforce. That means both supporting competitive salaries, but also supporting other types of workforce investments, like ensuring that workers have opportunities for training, professional development, other sort of life supports, focus on well-being. There's a major focus on recruitment and retention of the workforce, and that costs money. And so we have funds that are dedicated to investing in this workforce to really pull people into behavioral health and pull people into crisis services in particular. We're investing in a crisis training academy that will focus on the sort of best practices for working in crisis facility settings, as well as post-crisis follow-up. There's some solid training content, obviously, for call centers. Vibrant and others have done a tremendous work implementing trainings for those settings. Mobile crisis tends to have quite good training that's out there. There's a lot of good materials, but crisis facility standards for trainings, there's less developed in that space, at least here locally. And so we're providing that investment to ensure that folks who are working at these crisis facilities are really operating with absolute, evidence-based best practice approaches as much as possible, as well as supporting those post-crisis follow-up programs, which is a pretty novel and innovative program design that's going to need some training supports as it's implemented. Strong focus on continuous quality improvement, quality assurance and oversight. We have to develop audits and really take responsibility again to ensure that our providers are meeting expectations. There's funding that providers have access to for their own sort of self-determined needs around capacity building and seeking technical assistance. This is something I'm really excited about, standing up a process where we're engaging with trusted leaders to help the county define success. We don't want to be in the county sort of, in an ivory tower, isolated, making up what metrics we think are the most important. We need to do that in partnership with community. So we're investing in funding to actually recruit trusted leaders, sometimes also called credible messengers from the community, people who are familiar with the crisis system, who are also deeply connected to the communities that we're trying to serve, and include them in the process of defining what our priority metrics should be. So that, again, that's a mechanism for accountability. We're closing that loop. We're really directly working with folks to hear from them about what they think matters and make sure that, again, our services and systems are actually meeting the needs of the population. We're investing in a crisis care coordination platform where this is a new tool that will integrate multiple different data systems, including behavioral health provider electronic health records, which currently is a very fragmented data landscape, in order to get all of that information to one place, in order to inform crisis clinicians as they're doing, triage and risk assessment and seeing folks. They need to have access to that kind of information. We're also going to run a population health survey, and we're investing in partnerships with academic researchers in order to do rigorous evaluation of much of what I just described. So these are the ways that we're implementing accountability in our system. I shared this just to say dashboards, dashboards, dashboards. We've got a ton of dashboards. These are the ways that we're tracking our data through, really across the entire continuum within each component, but then also at an overall crisis system level. So we are very fortunate here in King County to have these resources, and I hope that many of the implementation activities around our accountable entity functions will be of interest to folks, as you all hopefully can identify fund sources to support similar activities as you stand up your crisis systems. So with that, please follow along. We have a website, we've got a listserv, we have an email address. We'd love for you to stay engaged in what we're doing as we continue to implement this work. And here's our departmental contact information. So thank you so much for your attention, and looking forward to the discussion.
Thank you, Dr. Goldman. There is much to learn from King County's crisis system and the way that they're moving forward with services. So appreciate you, Dr. Goldman, for sharing all of that. Now we want to move to the roundtable, and we want to invite Dr. Phil Moore and Dr. James Dove to give their take and share a bit more on what Dr. Goldman just spoke about.
Good evening. Hello, it's James here. I'm in London. I'm one of the medical directors in one of the mental health providers in North Central London.
Hi, I'm Phil Moore. I am a GP by background, a family doctor, and I currently work as Emeritus Clinical Director of Mental Health in London, particularly working on mental well-being and suicide prevention. James, do you want to go first?
Yeah, I mean, fascinating, and thanks for the invite. And I'm really enjoying these talks. I think from where I sit, you guys are on episode whatever 200 and something, and I'm coming in episode 1. I think the everything you're talking about just chimes so much with everything we're trying to do in London, in the UK anyway. I think everything you talked about, Matthew, I think particularly these crisis centres, I think I'm interested in. I think obviously with the socialised medicine that we have in the UK, it's a slightly different landscape. So we have mandated crisis mental health response teams that have to be able to respond to you within 24 hours. But the gap that is also true for us is these crisis response centres and what they look like. What I'm interested in from what you talked about is that you seem to have sort of 3 different models of these crisis centres where we've got I've been invited into these conversations because I'm now leading one of the discussions Pan London about what our emergency response centres look like. I was also interested in the earlier conversations about how many do you need per population and all of those kind of things. So we're quite early days. We've been doing these units for about 5 years. I'm interested. We've just got the one mental health assessment unit, really. You've got these different models. So I'd be interested to know more about those kind of things.
Well done, Matthew. I think that's absolutely stunning. I was just trying to do a rough back of the envelope calculation, it sounds as if it's about $100 per person per year to get to the 1.2 billion, as far as I could roughly calculate, which actually, when you put it like that out, isn't a huge amount of money. However, that beside the point, well done for getting those things in place. I think what you are doing that I am impressed by is you are trying to put together something that is cohesive and hangs together and is obvious for people who need to use it. I think one of the things, and I think James will probably agree with us in the UK, is there are mandated things, but actually the system doesn't always hang together as well as it might, and it tends to be a bit fragmented. Some people are doing one thing and others another. And I think that need, particularly for people with mental health challenges, that need for something that is cohesive, coherent, and obvious and easy to follow is actually a very big need, and well done for what you're doing towards that.
Yeah, absolutely. And I think that the data, what you talked about, the data in terms of the fragmentation,
Absolutely.
I mean, just so difficult to pull that together, whatever system you work in. I think that there's multiple dashboards, multiple providers, but the data is key. I was having a conversation with someone where I work today just about, if you can't trust your data, if you can't pull your data together, then it's just really impossible to understand if you really are getting bang for your buck. If it is $100 per person per year for your population in Seattle or King County, then that is obviously sounds like good value, but have you got confidence that you're making the most of that investment? And I think it's only the data is what's going to show you that, isn't it? So being cited on that and having the data sources and your dashboards as a core part of what you're doing is got to be the way forwards.
Absolutely, James. Interesting. I've just been doing some work recently on soft systems methodology. And if you look at that, the feedback of monitoring so that you can make improvements is actually a vital part of that kind of process. So yes, data is important. I'm impressed that you've managed to get that, Matthew. So well done again. You seem to be doing a great job, and I will watch with interest to see how you progress.
Wonderful. Thank you both. Can we pull Dr. Goldman back into the conversation? We have just a few minutes here. I want to see if there's anything that you want to add.
Yeah, no, thank you for those comments. And first to say, it's not just me who's done this, a massive team of folks. So many people have contributed to this work, and we're very part of the levy also funds the county in order to be able to administer this body of work. And that includes our, performance measurement and evaluation team, our quality team. We have a dedicated role for behavioral health accountability to really expand and invest in this work. And so, I think often it comes down to funding. And again, that's where the opportunity to braid these different fund sources and really scale this up allows for the opportunity. But then that's where we're really trying to use these best practices around this accountable entity idea from the roadmap report to implement and really target the data quality tracking, everything you've described, the electronic health record integration piece through the care coordination platform is a beast. We're going to procure a vendor who we're going to, work with our IT department to be able to develop that solution. And it's critical because we don't live in an integrated electronic health record world yet. I don't know if we ever will. And so we are sort of preempting that and saying, listen, crisis clinicians have to have access to that clinical information for their clinical services. And so we're trying to do all these things. And I think we're very hopeful that it will improve the quality of care for folks who are responsible for serving. So thanks so much for your reaction.
All right, Dr. Goldman, Dr. Moore, and Dr. Dub, thank you so much for that wonderful conversation. And thank you to Dr. Goldman for also shouting out the entire King County team. So great to hear about the work that you're doing. And yes, agreed, David, just such a bold vision. And there's so much to learn from the great work that you all are doing. So thanks for sharing that here. All right, now we are shifting over to the briefing room with an update from SAMHSA, and we have Richard McKeon here with us today.
Thank you very much, Heather. The main thing I wanted to talk with you about today is to make sure that all of you were aware that SAMHSA yesterday announced a $231 million funding opportunity to administer the 988 lifeline. So we are all, very glad that this is now out there. It represents certainly a major investment in crisis care. I'd point out that 231 million is annual. It's a 5-year grant opportunity, which means that this is a more than $1 billion funding opportunity. So would encourage everyone to go to the SAMHSA website, take a look at this. And, we hope to have a robust process. And then obviously later this fiscal year, we'll be making an award announcement. The other thing that I would reference in this, the last time the Lifeline was recompeted was 5 years ago, and at that time it was just under 24 million. So this, really reflects the extensive growth that has taken place in there, and the engagement in promoting comprehensive crisis services that everyone on this call has been engaged in. Also on SAMHSA's grant forecast page indicates there are 3 other grant opportunities that we are anticipating coming out later in the year. One is for our state and territorial 988 grants. One is for our tribal 988 grants, and one is for our crisis center follow-up grants. And Matt, it was great to hear about how the state of Washington and Kings County is approaching the issue of follow-up, and I couldn't agree with you more regarding its importance. So would love to talk to you and learn more about that. So anyway, that is all from me. Thank you.
Thank you, Dr. McCann. Always great to hear from you. Now we will shift over to the NASHPID briefing room. See who we have with us today. David Albert, I will turn it over to you to give your update.
Thanks so much, Heather. Good morning, good afternoon, depending on where you are. Great to be here. Great to see everybody. I'm David Albert. I'm Director of Illinois Division of Behavioral Health and Recovery, and I'm joined this morning by our Chief of Staff, Ryan Rollinson. We're going to share some information about legislation here in Illinois for a telecom surcharge to support 988 call centers that went into effect last year. Before I hand things over to Ryan to dig into some of the details, I thought I'd provide just a little bit of background and context. I remember back when I became director of the division, at the time, the Division of Mental Health, back in January of 2020, I learned pretty quickly that Illinois had the unfortunate honor of being worst in the nation when it came to our in-state call answer rate for the Suicide and Prevention Lifeline. If I remember correctly, we were like hovering around 17 or 18% in-state call answer rate, and we were consistently, I believe, one of the top 5 utilizers of Lifeline services. So it was not only bad for Illinoisans, but it was a bad look for our state. And we really set out, to change this as part of our building out of the unified crisis continuum here in Illinois. And one of the things we recognized very early on, won't be a surprise to any of you, is that we needed to identify sustainable sources of funding. So we put a lot of time and effort and intentionality into working with many stakeholders, including key allies in our General Assembly, to identify ways to fund our call centers and also other pillars of the crisis continuum. I'm happy to say that our in-state call answer rate has, for some time now, exceeded regularly 90%. So we've really come a long way. And one of the things that's going to help us maintain that and expand crisis services in the state is the telecom surcharge that went into effect on July 1st of last year, thanks to legislation that was introduced by partners in our General Assembly and championed by a whole variety of stakeholders. That surcharge is expected to bring in somewhere in excess of $50 million a year. And I believe we're on track to meet that number. But I will hand things over to Ryan to add some additional details and share a bit more about that legislation and our work. Thanks so much.
Thank you so much, Dave, and great to be here. So, yeah, here in Illinois, we worked with an independent academic partner to complete a fiscal analysis of our state's crisis system a couple of years ago. This projected all the costs and revenues associated with the three pillars and made a lot of recommendations for closing the gaps. So based on that analysis, we worked with, we had some internal discussions about which potential revenue streams to prioritize. We initially settled on a 988 surcharge of 40 cents per line per month and received approval from the governor's office to pursue that legislation. We quickly learned that in Illinois, other monthly telecom charges like the 911 fee are collected at the county or municipal level rather than the state. So our friends at the Department of Revenue said, we can't really figure out how to do 40 cents per line. But we can use our existing telecom tax, the telecom excise tax, which had been set at 7% of the gross charge for intrastate or interstate telecommunications. We worked with them to figure out that we could increase that rate by 1.65%. That would bring in the same amount of money as a 40 cent per line per month charge. So we estimate it'll bring in about $50 million annually. We are, as Dave said, on track to hit that. We're about halfway there, halfway through our fiscal year. So this was introduced as Senate Bill 2120, sponsored by Senators Laura Fine, Mary Edley Allen, Mike Simmons, and Graciela Guzman. This 988 surcharge bill received a hearing in March 25 with no opposing testimony. Became part of a larger revenue omnibus bill that passed by a wide margin through both houses of the General Assembly. So we are thrilled to announce that retailers began collecting the increased telecom tax on July 1 of last year, 2025. We're using those funds in our statewide 988 trust fund to support our 988 contact centers, mobile crisis response services, and our living room programs, which are a form of crisis receiving. And this is going to really help ensure the stability of our behavioral health crisis system. And our main hope is that it will insulate these programs for any changes in state general revenue funding or changes at the federal level as well. So we're very excited and happy to offer insight to any other states that are pursuing similar sorts of measures.
Incredible work. Thank you both so much, Dave and Ryan, for sharing that. And wow, just what a difference this will make in the lives of individuals experiencing a crisis in your state. Thank you so much for being here and for sharing that and being willing to connect with our listeners today. Okay, moving along to Voices in Crisis Care. I believe we're going to invite Dr. Dove back up.
Wonder where you got that photo from. That's a weird one. Did I supply that?
I believe we found this on maybe one of your social media pages.
Oh, that is my elderly mother who unfortunately died a year ago last week. It was the anniversary of her death. That's in her nursing home in the Highlands in Scotland. She unfortunately had Parkinson's psychosis towards the end of her life. So that was a very difficult situation, managing her with old age psychiatry. Nice memory for me, but not so relevant to you.
Thank you for sharing that, Dr. Dove. Okay. Oh, go ahead.
No, you go. You're going to introduce. There's someone else joining as well. Sorry.
Okay. I do not know the other person joining in. my list.
Or maybe it's not, maybe it's just me, but maybe if you could just intro what you would like me to talk about. Sorry.
Yeah, that's okay. We want to talk about what the most important element is in terms of crisis care. The idea of having these niche or boutique services versus a core crisis care opportunity where anyone can access the service. Kind of your take on that and the difference between having one that's a bit more exclusive and then one that is open 24/7, that's accessible to everyone.
Yeah. I mean, I think it's a really interesting question. I think a lot of the conversations that have gone on today sort of touch on this about if you have niche and boutique services, how are people really going to understand what they're for, what they're offering? How do you standardize? The problem with units that have the lights on open 24/7 is that then perhaps you attract more attention than you might like. So I suppose one of the things that David said when he asked me to talk today was thinking about, well, what the litmus test really is for crisis services and how we can tell what is the right thing to be doing. I think for me, speaking from a UK perspective and speaking, I guess, from thinking about these mental health assessment units, the 24/7 health mental health assessment units in the UK model, really, because we have, as I said, we have the socialized care and we have our A&Es. I know it's the same system as you, but the lights are on, people can come in, there is no cost to the individual, it's 24/7. So what we're doing with mental health services is trying to stop people from walking in to the brand that they all know. It's free at the point of access. You walk into A&E, there are no charges, there is no question of insurance, your postcode is not checked, and you know that your needs will be met. So people don't necessarily mind. They may have to wait a long time, but they know that eventually they will be seen. However, in mental health services, we know that that is sometimes a complex, messy system. A&E services are not set up to really help people in a mental health crisis. We have the problems of data not kind of connecting. So what we're trying to do is have another unit where the lights are on 24/7, which is mental health specific crisis assessment centers. So I think the litmus test, how can we tell we're doing a good job, is are we reducing the numbers of people who are actually presenting at that front door of the acute A&Es? If we are dinting the actual front door attendance and people are choosing to come to our units, then we're on to a winner, really. I think the second thing is that we talk about and how you can tell whether things are working is thinking about the outcomes that we're getting, obviously, and obviously that there's multiple patient-related health outcomes from all of these units. The thing that I always try and get people to think about is when we get people straight to the front door of our units rather than going through the EDs. And I was interested at the start of your session today, you talked about the votes on do you need medical clearance or not, and I was really pleased to see something like 72% of your listeners or your watchers are saying you don't need to go via ED, you don't need medical clearance, and that's the message I'm really trying to get across in the UK. But we struggle with in the UK because people are so wedded to medical clearance and getting people through the door of ED, or let them just go and get a blood test first. And we have very different figures, sort of the opposite way. People saying that you have to go, 70% of people have to go via ED. But I'm really pleased to see that you get it, because when people go through the door of ED, you're more likely to get a restrictive outcome in mental health or behavioral health. We know that from our data in the UK, because people escalate in those environments, people get restrained, people get secluded, and then you end up with a restrictive outcome of people going into inpatient services. We know that if we actually look after that patient from the minute they walk in and we don't bother the door of the non-specialist service, then we can reduce the number of people we're admitting, so keeping people in the community. So I guess, I mean, I don't really know if I'm answering this question entirely, but I think for me, the litmus test and how we can tell if we're doing a good job is, are we reducing the number of people who are actually going into generic EDs? And are we reducing our restrictive outcomes overall? I think niche is problematic because you're only ever going to serve a very small population.
Right.
I think you've got to have an open door. You've got to have the lights on 24/7, because for us in the UK, you've got to compete with what people know of the ED.
Yeah.
So
Dr. Doug,
that's my
thank you
headline.
so much. Thank you very much for joining us and for coming back up. It was so great to have you here. And for everyone who listened in today, I'm going to turn it over now to Kristen to wrap us up.
Thank you, Heather, and thank you. Congratulations on your first hosting gig. It was great. Thank you to Matt Goldman for today's conversation on Washington's levy and how crisis systems are continuing to evolve. Of course, thank you to our headliner sponsor, AHP, and for their workforce segment earlier in the episode. Workforce continues to be a cornerstone of effective crisis care, so we really like that focus. Quick shout out before I talk about Crisis Now 4 to a couple of our jammers. Congratulations to Heidi Warrington and Tanasha Hildebrand, who were randomly selected from the chat to receive crisisjam.shop gift codes. Thanks for being such active participants today. You'll get an email from Marie Eddy with your gift code. Crisis Now 4 is coming this July in Washington, D.C. Registrations are already rolling in. They will sell out. So if it's something that your organization is thinking about attending, go ahead and go to crisisjam.com and you can check it out. Next week, we'll be joined by Dr. Tom Insel, who talks about what happens after a crisis. And in 2 weeks, we'll be talking to Dr. Catherine Warburton, who will join us with a frontline perspective on homelessness and crisis care. 2026 is a great new year, hoping to be exciting and dynamic. Thank you so much for watching. Be sure to tune in, log on, join the movement, and we will see you next week.
Thank you.